This is a podcast about our lived experience, which unfortunately includes infant death and subsequent mental health struggles. Please take good care of yourself and only listen if this content feels safe for you right now. We'll still be here when you're ready.
Hi, I'm Judith.
And I'm Alina. We both lost babies to SIDS in winter 2021.
In the throes of grief, I reached out to a stranger on the internet and our friendship was born.
In the years since, we've been working hard to survive, rebuild, and navigate the continual challenges that have come our way, including divorce,
job loss,
dating while bereaved,
moving multiple times,
health scares,
pregnancy and parenting a living child,
starting new jobs, and so much more.
We are tired.
Happily ever after is out of the question for us, but this podcast documents our journeys to happier ever after because we believe life after loss is worth living.
So join us as we laugh, cry until we laugh.
Welcome to As Long as I'm Living podcast.
We're so glad you're here.
As a reminder, you can find Heather's information in the description of this episode. If you want to chat with her on Instagram, she's super responsive there and does amazing advocacy work. You should definitely follow her. And without further ado, I'm going to send you into the episode. Enjoy.
I can't tell you how many patients I took care of during my residency who, when we diagnosed them with a stillbirth, they actually didn't come in for fetal movement concerns. They came in for a headache or their water broke or they thought they were in labor. And when we said to them, when did you last feel your baby move? They almost seemed unsure. And I honestly thought it was denial. I thought when somebody came in like that, they really just didn't, they just couldn't face knowing it. But in reality, it was a complete shock because their family members told them their baby was sleeping. They never heard anything different from their OBGYN or their midwife or their family practice doctor. They just heard these vague count the kicks things, but not telling them to get the app, not telling them to know their baby,
I wasn't even told to count the kicks. I said to my doctor, I was like, should I be counting something? Because, I pretend I'm a doctor. So I said, should I be counting something? Like, I've been reading about this. And they're like, oh, just make sure your baby's moving every day. That's what I was told.
My OB, when I was pregnant with my son who died, again, not a stillbirth, I said, should I be counting kicks? And she said, we find it alarms people. If you find that his kicking, if you feel like his movement is abnormal for him, which I actually do think is good advice, but correct me if I'm wrong. Yeah. If his movement is abnormal for him, then call. But I said, should I be counting kicks? I'm reading all this stuff about counting kicks. And she was like, we just find that it unnecessarily alarms people. And I think back and I'm like, okay, but if I wasn't someone who was so highly attuned to his movements, which I was, but maybe people should be counting kicks. Maybe just a thought.
Well, and I think one of the things I always get concerned about is there's this study, I think it's from like the late 70s, early 80s, that came up with that if your baby's moving 10 kicks an hour, your baby's fine, which I really hate because I think there's some babies that move 10 times, just me simply looking at the mom's belly during the visit. So I want to never have somebody do a kick count when they're worried. I want them just to call. But Count the Kicks research shows that using their app and getting to know your baby actually decreases anxiety and improves bonding. So we're using this old data. And again, telling somebody that if they change a litter box, their baby could die is incredibly scary. Why we feel like, I remember when Zika came out and we were all terrified that every baby is going to have microcephaly, and we're telling people not to travel and to not have sex for 9 months. And we're doing all these things. That's incredibly terrifying, but we can't empower a patient to know their baby and their body and call us if things don't seem right. I think it's such a flimsy argument, and it's so aggravating to me. And it's also very, I think, patriarchal to say, I can't tell this to a pregnant woman because she's so fragile, she can't handle it, but I can tell her about those litter boxes and those cold cuts.
Well, I think part of it is that women are not necessarily comfortable advocating for themselves generally. I think that generally we have a hard time asking for what we need, standing up for ourselves, demanding attention. And so I know that's also part of it. But I also I want to agree with what Alina was saying earlier, that there are doctors who are saying that it makes you unnecessarily anxious. And it's the same thing also with the owlet, for when the baby's born. They're like, oh, well, it's going to make you more anxious. It does more harm than good. I feel like there's mixed messages about anxiety in a way that for me,
Yeah, it's
if this is
counterproductive.
going to be, if this could save a life, not, you don't want your patient to be extra anxious, but also like there's a dose of anxiety that maybe could be healthy, of just awareness.
I like what you said, which is if you feel anxious, the step is not count kicks. The step is call your doctor,
Yes.
right? If you are feeling like something's off, call your doctor. If you want every day, maybe you regularly count kicks at 2 p.m. and that's a wonderful thing to do. But like counting kicks is not, I'm feeling anxious about my baby's movement. Let me see if I can get him to move 10 times this hour and drink orange juice, right?
This is a very important piece, is that please, anybody who's listening to this, do not use a home Doppler when you're worried about your baby's movements. I have seen so many patients who use a Doppler to reassure themselves and their baby died soon after. Babies
something was off, right? They used the Doppler, heard a heartbeat, and were like, oh, it's fine.
Yes.
Right.
And then a day or two later, something happened. And so babies can have a heartbeat that's like in the 140s and actually need immediate delivery. And so you really can't use that Doppler if your baby is not moving. And I've been working really, really hard to try to get them to put a disclaimer on their sites, and they keep on telling me that they will, and then they don't.
So when is an appropriate use of a Doppler, an at-home Doppler?
Appropriate use of a Doppler at home is your baby is moving like crazy and you are not the least bit worried and you want to hear what their heartbeat sounds like.
Yeah. Or maybe before they've moved at all, or you felt them at like 16 weeks and you just want to make sure they're alive.
Well, I tell people, if you're going to do that, do it during business hours, because if you don't find it at 2 a.m, you're going to panic and then you're going to end up in triage with a $500 bill. So,
what exactly? So when you say, like, so explain to me. So when you say, when you feel like concerned, you should call the doctor. So like, what would be concerning behavior for a baby?
So it's different for everybody. And so that's where the Count the Kicks app is very helpful, because it says if somebody is doing the kick count at a certain time, it will say your baby doesn't seem to be making its kicks like it usually does. It will help guide that. I will tell you that it just seems like an instinctual thing. Kind of like breathing. I describe to people, like, I feel like your baby's normal movements and you don't really notice until it's off, because it doesn't seem similar to the time that it's been. Similar to breathing. Like, you don't notice yourself breathing or your heart beating unless it's beating really fast or abnormal, or your breathing is abnormal. So I do think most people seem to say, you know what, they slowed down. Something doesn't seem right. The juice in the crackers, they've done studies showing that it really is never going to take a baby who's in distress and make them not in distress, which is pretty obvious. But what it does is delay things. And the other concern I have about it is, and one of the things we were talking about is empowering people to call. But if when they call, they get blown off, whether it's a provider or a nurse, and they say one of the myths, or they say, did you try the juice or crackers? Or your baby did move 10 times an hour, so your baby's clearly fine. If they don't feel empowered by that conversation and they get turned away, either something tragically happens then, or 2 or 3 days later, when the movement's persisting, they're going to say, that nurse or provider blew me off, so why am I going to bother calling again? So I always tell this recent story of a patient that we had who called all the time. And I think we're really good at our practice of always empowering it. And she called me 2 days before she had her baby with a concern that was not something people typically call in the middle of the night about. And my response is always, if this person's worried about this enough to call me, then I'm going to take it seriously. And I reassured her, and she was very thankful. And then a few days later, the baby wasn't moving, and she called immediately, and we brought her in, and she needed to be delivered and had a beautiful, healthy baby. If when she had called at that hour with something that was not, in my mind at midnight, something she needed to call about, but it was worrying about her, which is all that matters. If I had said, I cannot believe you woke me up about this, would she have called 2 days later that her baby wasn't moving? So unfortunately, there's the education piece for our patients and for the population who listens to these things. But if they get blown off when they make that phone call, then it's dead in the water anyway. And so it's such a multifaceted approach to be able to prevent this.
Well, that's a really good segue into supporting people who've been pregnant and lost. So I'll tell you, when I was pregnant with my daughter, there was one night that I felt something was off about her kicking. It felt like it was too fast, I think is what it was. Now, you have to understand the mental state I was in when I was like having this. Like I was in severe PTSD, severe shock. I was pretty checked out of the entire pregnancy. I was really, really messed up. But I insisted because I have so many friends that have lost children stillbirth and I've heard crazy, wacky stories. I was like, I just feel off. I want to go in. So we went in to the hospital. And they kept saying to me, there's no such thing. There's no such thing. Your baby can't move too much. Your baby can't move. There's no such thing. And then they were like, did you have juice? Did you have dinner? Did you have whatever they were saying? And I kept saying, something's off. I'm really scared. I feel off. And then it wasn't until I said, I have a son that died of SIDS a year ago from whatever it was, 2 weeks ago, like a year ago. I need your help. Like I need you to pay attention because I'm freaking out. Then the whole dynamic in the room shifted. All of a sudden, they like pulled out the this and the that, and they called the doctor and they like took me seriously. It wasn't until I said like, I'm having a severe, even mental health or not, like it wasn't until I kind of like cried wolf and said something's, I'm really scared. I have a history of sudden death that people woke up. And I feel like to me, that experience was the opposite of validating. Really made me feel like dumb for coming in. And I don't even feel like, and then once they assessed me and the concern was really my mental health, the doctor just said like, he's like, how many milligrams of Zoloft are you on? Like, I think you need more. Like, and that was it. And then he like left. And like, I was really, really vulnerable in that position. Thank God my OB is a wonderful, wonderful person. And she called me the next morning and I guess she saw that I went in and she was like, Judith, I'm treating 2 patients here. I'm treating you and I'm treating the baby and you're not okay. So like, let's come in and work on a plan to like make sure your mental health is okay. And she let me come in. I think I went in to test every other day, like whatever I wanted to reassure me, she was on board with. She would see me at her lunchtime, but that's a story of a hero for another day. But the point is that like, there are 2 patients, the baby, but also I wasn't okay,
And so increased fetal movement has been, if a baby is always active, that's a healthy baby. A baby that is having a sudden burst of movement, and then they go back to decreased usually to no movement is very concerning.
Thank you. Thank you.
Yeah. Nobody really knows the reason for this phenomenon. But when they've done large retrospective studies where they compared cases to controls, they found overwhelmingly that you didn't see that in healthy outcomes, but you saw so many babies where the mom said, I was, and it's interesting because this isn't the thing that you take out the video to videotape because it's so comical. This is, people described it as crazy, frantic, worrisome. It had negative adjectives to it versus the babies that I see and I'm laughing with the mother because this kid is like rolling all over the place. So it's a distressing feeling to people who experience it, and it should be taken just as seriously.
Yeah, I can almost hear people listening to this at first being like, oh my God, like a lot of pressure, like I have to be monitoring the movements. But I think like the takeaway that from what I'm hearing from you is like, you'll know. It'll be weird as hell.
And if for some reason, I always want people to say it, yes, it'll be weird. If for some reason you don't know and this tragedy happens to you, it's not your fault. It is never the fault of somebody. Sometimes, unfortunately, it suddenly happens. So, for something like a cord accident, it may be a sudden thing where baby goes from fine to unfortunately passes away in utero. But for babies who have a chronic issue or babies where they're just slowly running out of steam, the decreased fetal movement may be the sign that they need to call about. So it is never somebody's fault if this tragedy happens, and we can't prevent all of them, but we certainly can give tools to say if your instincts are something's not right, whether it's a headache or your palms are itchy or you're feeling like you're in labor, you should be just calling and running it by us. One thing that I think is a positive light when I think and reflect about the 4 years I've really been advocating for at my hospital for change is change happens relatively quickly when you start at the beginning. I hate the phrase, maybe I don't hate it so much because I'm using it, but you can't teach a dog new tricks. It's true for nurses and doctors and anybody else in the healthcare team. People at the twilight of their career don't believe, and I heard some very insulting things when I started to change things, but fortunately or not fortunately, COVID has kind of made the more senior people retire. And we brought in newer nurses, and the newer nurses have really never known nursing where patients didn't come in for the concern of decreased fetal movement in our hospital and get taken seriously. And that's always forever changed now. Once you change the culture, it's done. But you have to get the people out who are just constant barriers to the culture change. And I think that's why I'm trying so hard to reach residents and trying to give them this education and trying to reach from the beginning. Because if people learn from the very beginning the right way to approach decreased fetal movement or the right way to approach a patient who's lost a baby, then they're going to always follow that. You can teach and you can learn, and it's something that can change.
And they'll go to whatever hospitals they wind up at all over the country. And so you teaching residents in one small area of New York might wind up with, in 40 years, hospitals that have completely different practices, like for the better, right? Even though it's a small subset of people.
Yeah. Well, that's definitely the hope. And I don't know if you saw, I created like a book of tips that is on my little Instagram page, because I made all these tips and then I created them into a little Shutterfly book. So I'm, as I said, getting on my soapbox with the residents and giving them the books, but I've also mailed them to several other hospitals, and other residents are going to get them, because if we teach them how to take care, and there's no structured training right now through like ACOG or ACGME, who like kind of sets things and all this kind of stuff, then at least we can do it on the fly. At least we can do it in a more organic kind of grassroots way. And again, I've seen the culture shift from the nurses, and the turnover of COVID has been really wonderful to see. When I started first advocating for more attention to people coming in with fetal movement concerns, I heard from more senior nurses things like, you're just going to overflood this place. People are going to use their babies to get delivered. They're going to use it as an excuse to get admitted, and just these really insulting, condescending things. And thankfully, and I've heard this from not just our hospital, but all over the country, from what people have heard from nurses, when they came in for these concerns, I can guarantee you none of our nurses would say that at our hospital now.
What a ridiculous, I just love being admitted to the hospital. Like, let me do it 15 times just for fun. Like, what?
Well, can you talk a little bit about how you care for people who've been through loss differently?
I know we've been meaning to get to that one. And then
there's just so much to talk about. I'm just curious, like, what do you recommend to other OBs to do differently, and what are some of the things that you see commonly, and how do you reassure people who are really, really, really anxious?
So I get a lot of transfers. If they're my patients, as we kind of work through the grief process, we'll talk about next time, that kind of stuff. Everybody's different. Some patients want my practice. We rotate through different providers, and there's some people who feel very comfortable with that. They want to keep things as normal, quote unquote, as possible. Some want to see me and only me, or maybe they want to see my partner if it was them. So we kind of set the roadmap from the beginning, though. I make sure they've seen a high-risk OB. We talk about what their needs may be, make sure they know what we're going to do to hopefully prevent a recurrence, kind of have that roadmap set. And then I really tell them that it's their choose their own adventure. I have lost moms who found the NSTs, especially if they've had a baby after loss, they found non-stress tests to be more anxiety provoking and not the least bit reassuring. Then we don't have to do them. If they're comfortable in their baby's movements, we'll skip that step. We talk about our ultrasounds, but I really let them guide me. I have had patients who do great the whole pregnancy, and then like the week leading up to induction are like, I need an NST every day. That's what we'll do. I have patients who declare at 22 weeks they need to see me every single week until this baby comes out, and we figure it out. So it's a very patient-guided care that I provide.
That sounds very similar to my OB, and I've never heard or seen it before until this experience. I don't think it's like normal, but I cannot tell you how helpful that was, because you're already in the situation where you feel so powerless and so out of control, and you feel like you're just at the whims of whatever wind blows. And for someone to say, you're in control, you tell me how frequently you need me, it feels so comforting. It feels like finally that's something I can do. Here's an action that I can take, as opposed to everything just happening to me, And it feels like I think also part of it is it helps me become just a more informed patient because I don't, before you don't know what you don't know. But when a doctor says, do you want to see an MFM? Do you want NSTs? Want more? What would make you feel reassured? I feel like I'm seen more as like a whole human, like a human with anxiety, a human
and
with
not just a uterus with a baby in it.
Yeah, I'm not just a uterus. Like I'm a human.
You're an actual real human being. And
human being.
I can very rarely, if ever, think of a pregnancy after loss mom I told she was being overly anxious. Or said we need to do something about this medically. One of the things I talk about with like people when we're educating is I cannot tell you how many patients I've had who hit the 3rd trimester especially and say, can you just put me in a coma for the rest of pregnancy? And I don't think that is unusual. I
Judith said that all the time, like literally every day.
Oh my God. You know what? What happened to me at the end was I couldn't sleep at night because my son died when I was asleep. And so I just didn't sleep for days on days and days and days on end. And then my doctor eventually said, like, you have to sleep. And I don't know, she probably prescribed me something. I was only allowed to, what was it, Alina? Do you remember?
I feel like it was just Benadryl.
No, it was strong. It was.
Oh, okay.
It was whatever.
You were trying Benadryl at one point.
I was getting, but I remember said like you have to sleep, and I feel like
I remember you expressed to me essentially that you felt it was all on you. You were fully in charge of keeping this baby alive. You felt all this pressure because at least when the baby was born, there were 2 parents who could be watching the monitor. But when you're pregnant with the baby, it's all on you. Right. I remember you felt a lot of pressure to keep her alive. Like it was all
a lot of pressure.
Yeah.
I do a lot of the, so again, always validating, always helping, but never making somebody feel like I've had patients say, I think I'm going crazy. And I'm like, you're not. And like actually saying you're not going crazy. Let's make sure we have resources to help control these things, but it's validation. It's not. I've never seen a pregnancy after loss person who I thought was worrying too much, being too anxious. I've actually thought it was actually very normal the way that they were feeling and responding and being. So
I appreciate you saying that.
Yeah, I've never. I mean, and I've, people have extreme anxiety. I mean, it's normal. It's, it's something that you don't believe you're going to, in the case of stillbirth, hold a healthy baby until you do. And it feels the closer you get, the more I'm almost there, but I'm not going to get there. And so just setting a due date, I think helps, like we're going to deliver you by date, can be very helpful. And again, it's just about kind of empowerment. It's about talking about the baby they lost, not like brushing aside. One thing I did find very helpful in my pregnancy and I kind of use is I was incredibly optimistic during my pregnancy, despite how incredibly high risk it was. And the reason why, and I did some really goofy things, and I tell my patients about my goofy things I did to like maintain my optimism, but I did it because no matter what happened, I never was going to beat myself up because it was my negativity, my pessimism that made this happen. I knew I put all my positive energy into it. And I tell people, I want you to believe in this baby. I want you to put your positive energy into it too, because the recurrence risk is very small. But if something tragic happens again, I don't want you to blame yourself for it. And I think, and I tell them all my corny tricks and, but
I think part of it is also the closer you get to the end, at least for me, it felt like the closer I was to bearing another baby. It didn't feel like there was a lot to look forward to because the only experience that I had was death. So it was like a countdown to death. And to me, there was like the first trimester, I think you're so sick or whatever it is, you're kind of checked out. The second trimester, I felt really safe because I was like, okay, like and then the 3rd trimester, I was like, oh my God, I'm gonna have to bury another baby. And I feel like it was so hard to convince me otherwise because that was the only experience I had.
100% of your children were dead.
100% of my children were dead. And I felt like my OB, I actually had 2, let's put that aside. The first one I moved out of LA, but I felt like for him, he had seen so many living babies and so many times where things worked out. I couldn't get him to understand that my mindset was different. For him, he was like, it's rare, there's so many, everything's going to be fine, everything's going to be fine. And that was so not reassuring for me, because from where I was sitting, my evidence was, and I know you see hundreds of living babies, but that wasn't my experience. So I felt like that was so not reassuring for someone to say, that's gonna be fine, everything's gonna be fine, it's gonna be fine. You know, that's not helpful to me.
No, I mean, you can never promise people anything, unfortunately, you know, and it's, you can't present odds to somebody who's experienced stillbirth or SIDS, because to them it's like, well, you told me that, you know, you told me the odds were 1 in 160 that I was going to lose my baby, and I lost my baby. So it's always hard when we have things that show up that aren't common, when I'm talking about that it's rare that this will be anything serious, because to them, to mind, everything to me is gonna, you know, so it's really kind of negotiating through it and really trying to convince them, when I'm truly not worried, like about something, that I really don't want them to be worried about it. And it sometimes just, you know, you can't, you know, I think you have to develop that trust though. Like, I think I hope my patients who I take care of after the losses trust me so much that when I look at them and say, I do not want you losing sleep over this little bit of information, they know I wouldn't say it to them if it wasn't true.
Yeah.
And what about TFMR? Because that's slightly different. How do you deal with those cases differently than a stillbirth case where it's sudden kick count, you know, being aware of your baby's movement?
Yeah. So usually it starts with, like, you make the devastating diagnosis. Usually I will say to people, there is no judgment here. You kind of do what you feel most comfortable with, and you'll have our support, our team support, everybody, you know. And I always tell people, you don't know what you're going to do in the situation until it happens to you. So you may think you're the most pro-life person on the planet, and in a million years would you have do this. It is not true unless it's happened to you. And I have overheard conversations, even when I remember I was on one of the other floors in the hospital, and somebody was talking about somebody who was terminating after an abnormal screening test. And they were like, well, I could never do that to my baby. And I said, you have no idea if somebody else in this who's hearing this has done this. I basically called her out on it. And I said, this is not appropriate conversation to be having. Somebody who's overhearing this could have had a termination for medical reasons. And I kind of corrected her, and I said, I'm sorry, you really just don't know until if it happened to you. And, you know, she actually thought about it, realized it was an OBGYN having this, and we actually all kind of had a thoughtful conversation about it. And so I think that's the first piece, is just saying, I am not making, this is you, not my, no judgment, just here to support. I do have a little bit of bias when we talk about once they decide to terminate the pregnancy. I do think, and I will express this to them, that I think if they're far enough along labor and delivery versus the surgical side, and not from any other standpoint other than the bonding part, unfortunately, you can't do that at like 13, 14 weeks. So we're talking more, you know, 20, 21 weeks, that kind of stage.
But I'll say we've talked to lost parents, TFMR parents, who their regret is that they didn't deliver, as opposed to their regret being that they had a TFMR. Yeah.
And I think for some people that's clearly, and I've learned as a provider that I express my bias, because I think if I express it, it's a little bit less than me not expressing it, and then they can hear it. And I just say to them, and obviously, as I said, you have to be a certain gestational age before we can actually do that, because the hormones, and it's just the placenta is probably not going to separate at a certain gestational age, you know, having a baby to truly hold, that kind of stuff. But when we make this diagnosis at 17, 18 weeks, it's whatever makes them feel the most comfortable. But certainly if they ask me what I would do if it were me, I would have done the induction, just because it allows the bonding in a way that they may not get. And while it may feel the harder choice at that moment, I think for the patient who I bonded, I know really well. And again, this is also me though, giving them a little bit of bias, but also assessing where they're coming from too. Saying you need to do what makes you the most comfortable. And if the surgery is what you need to do for you, then that's what we do. So it's really, and letting them know that just because they have the surgery, they can still name the baby, they can still, you know, do all those things too, is
and
important.
Miss them and grieve them and all
yes
of that.
Yes, it doesn't change the grieving aspect. It's, do I want to know what they look like? Do I want to have handprints, fingerprints? Do I want to dress them? Do I want to make those memories? And as I said, I have a little bit of a bias towards it, but I kind of try to express it to my patients that, and that's just from experience. And
so let's talk about that because now, okay, so that's kind of the TFMR specific part of this, but let's talk about like, how do you care for a patient having a stillbirth or delivering a TFMR? Because we've interviewed, I have a friend who has a charity called Empty Arms, and they provide education in the state of Massachusetts for how to take care of newly bereaved people. They are companions in the hospital, and they do the handprints, the footprints, they take all the pictures and everything. And I know that there's just such a lack of education about what's even okay for patients to ask for. Or what to encourage patients to do. So like, what do these patients look like?
And I should also make clear that my bias is because my hospital does a phenomenal job. So if I didn't think they were going to get phenomenal care when they came to my hospital and deliver their baby, I would probably have a different bias, right?
Yeah.
So it looks different from stillbirth versus pre-viable, like preterm labor are very different than diagnosis of anencephaly that you decide to induce. Those patients actually have time before, so I can actually give them advice before they even come to the hospital, telling them to, so we provide at the hospital books for them to read their babies. We have necklaces, we have bears, we have dresses, we have all the things. But people who know, they may have something special that they want to bring. They may have something special. So I'll say, like,
or
if watching your
take
favorite
maternity
movie,
pictures, like
exactly,
if you're
exactly.
going to terminate, you can still remember that pregnancy and take some photos. And
One of my lost moms, who we do a lot of teaching together, she one of her twins passed away a few weeks before she delivered the boys, and she took them together to the zoo and to the science museum and to a park, to a playground, all those kind of things. So those are things that you can definitely much tell somebody who has some anticipation of the grief they're going to go through. The hardest ones I find, honestly, are the pre-viable preterm labor, because they often come in with a little bit of spotting and then they lose their baby soon after, and they've had absolutely no mental time to prepare. So I find those incredibly hard, because
those are people who they have incompetent cervix or something.
Yeah, because with stillbirth, again, I'm not saying the level of the loss, but like preparing, when we're talking about preparing, they often come in and they are in a little bit of pain. They have pink discharge, and then they're pre-viable, so they're already 4, 5, 6 centimeters. And by the time we counsel them, get them in a room, they're already delivering. So family can't get there. They can't even wrap their head around it. Versus with like a stillbirth, we have time for them to grieve hysterically. We have time for them to think and process. And one of the nurses, when I first came as an attending, actually was the first time I ever saw somebody offer for them to go home. And that can actually be a really good suggestion, is to go home and come back the next day. It feels like a weird suggestion when I first started, but I think it's a really good option, because that way they're still going home with their baby and they can grieve with their baby still with them, and even start to kind of just unpack that a little at home and what that's going to be like with their baby still with them, and then come back and have their baby. So that's kind of, the preparation stuff. If they choose to stay, I mean, our hospital, we have so many resources, and As They Lay Me Down is a photography group I think you were maybe mentioning. And their nurses do phenomenal photography. And when I deliver these babies, if it's something where they've anticipated, they kind of know already kind of what they want to do. But as I said, I greet them very similarly and start to quickly comment about their features, and kind of really try to help them start making those memories, because they really are looking to us as their team to help show them. So my lost moms and I created libraries that we have in 13 hospitals around Western New York, and that we have books that they can read to their babies and sing to their babies and take with them to kind of start a little library in honor of their baby. And it's really great because we have 3 labels in them. So one says this is dedicated in honor of, so in honor of a baby that was lost. And then we have a card for information about resources and who to get in touch with if you need help. And then a thing that said this book belongs to. So they can write this books belong to their baby. And then if they have older children at home, that can become part of their library, or their children they have after can have books that they know were read to their sibling. So it was something that we didn't intend to be as crazy and big as it became, but it just kind of exploded. And so I guess, as I said, I want to make very clear that my bias there is just because I know that our Highland team is phenomenal. And
so what do you do after I'm saying, how do you take care of yourself after you deliver?
Yeah.
How does it feel being on your side? What are some of the thoughts going through your head? And then what do you do when it's over for yourself?
That's a great question. I think I'm pretty good at self-care and self-reflection. I always tell people I think it's good to grieve with, but they don't have to support me. Like, I don't ever ask, obviously I don't say, here's how I'm feeling, but I find that my supporting my parents helps me through it. I think I do have a little bit of that. This sounds terrible, but I love the show Charmed. It was like my favorite show when I was in high school. I don't know.
I watched it.
And one of the witches had an empath power. And I kind of talk about that. Like, I feel like I tell people I can handle it. It's one of the things I say to all my acutely grieving patients, that don't be afraid to use me. I can take it. And it's not that I don't feel it, but I think I've been, I don't know, for whatever reason, granted the ability to not let it swallow me. And maybe it's focusing on, as I said, I never doubt for a single minute that I am doing good work, and maybe focusing on that more than anything. But I don't feel like it drags me down. I feel like it lifts me up, and not in the, is of course incredibly depressing and sad, and it's grief, but it's why I'm here, and it's my honor. And I think I look at it from that angle. Is I have so many patients who just say, I couldn't be here if it wasn't for you and what you've done for me. And that to me is worth any infringement on my time or my mental health. And does that make sense? I think it just,
your patients are very lucky to have you.
That's for sure. I mean, I don't really want to move to Rochester, but I do want to be with you.
It's one of those things. It's funny. Like, I'm always like, if you have doctors who you think want to learn, just have them join this. We need more members of this club in the provider side. And
I'll ask
is there like a directory that we can start for this? Because I feel like this is, I guess, the Rainbow Clinic,
you know what,
right?
I did? When I moved, like I said, I moved at 24 weeks. So I moved across the country, and I just went to all the support groups. That it was horrible. I had to call all these random strangers and be like, who are your doctors? Who's your doctor? Who to go to? Because I needed help. I needed someone who I wrote compassionate,
trauma-informed.
Trauma-informed, compassionate doctor. And it was not a success. I mean,
no,
that didn't work.
It's people might claim themselves to be experts at it. I think honestly, the best way to do is go to ask a bereaved mother, what they'd recommend, ask the stillbirth groups. There's, there's, as I said, that I wish there used to be a bereavement kind of specialty for nursing. In my dream world, there would be a fellowship for people who want to do this work. People like titles. Titles make people happy. I don't get any extra titles after my name for this.
Yeah.
If there's a special title or plaque, I could have, those people who have to put all their degrees and letters after them.
No, but you're well known in the lost community, because when we posted, we asked for recommendations. I can't tell you how many people recommended.
Well, we got a bunch of people listing their random doctor who doesn't do podcasts or anything, which is fine, and we would have been happy to have it. And then we got 7 billion of you.
Yeah. Well, Alina, what's coming up for me as I hear Dr. Florescue speaking is how different their experience of losses with ours.
Yes, 100%.
How compassionate, how kind, how caring you are. And to think of the first responders that I dealt with were the police. and how uncaring, I don't want to say uncaring, how cold, how investigatory the whole thing felt. You know, I don't even know if that's a word, but there was certainly no one there asking me about handprints or hair print. It just sounds like in the hospital setting, there's space for love, and there's just an understanding. To me, it just seems like you treat their patients as grieving parents, as opposed to me and Alina, who were treated as what?
Potential criminals.
Potential criminals. And how much more healing that experience would have been for me if I had the chance to, like when I had to say goodbye, I wasn't allowed to hold him because I don't even know, maybe they were like worried about fingerprints. I don't know. And like to go through an entire investigation that morning and not to be able to like hold on to his clothes. Everything was put into like evidence or whatever. To me, how cruel that was, because I was a grieving parent and these were the last moments that I would be in the same room as my son. And I would have loved to have just someone to shepherd me through that process, who cared, who knew what was going on, who could speak to me as a grieving parent. And I just feel like you're right. Like people probably, you are transformational in their experience of loss, because I didn't have that. And I feel there was a huge void. And I
honestly,
feel so jealous.
A lot of stillbirth parents don't get that either, is the really horrific, sad thing.
Yeah.
Oh, the studies show that too. And it's funny. So I'm always thinking of new ideas. I hear what you're saying, and I more projects I always come up with. But
you want to go to LA?
You guys are like the same. Judith always has like 10 projects.
You want to go give a talk to LAPD because they could use it.
What I was thinking is, when they get a call for something like this, send out a social worker. Send out somebody who is going to say 99.9% of this, there was no fault, who's there to put their arm around the person and not have a bias towards it. Right. Because yes, those people have their job, but I think about that and I think of what percentage of those families where they go out to a baby who the parents call frantically after what you guys went through. And why can't you have somebody who's there for the mental health of the parent?
They sent a social worker, but it was a social worker for my son on his behalf to investigate me for neglect. They should also be sending a social worker that is my social worker to usher me through the process and say, here's, you're going to answer questions from the police, et cetera, right? As opposed to, because I know they have to investigate, and I actually totally respect that that's part of it, because people shouldn't. Yes, I can appreciate it, but you're right. Like there's this whole other side. You're treated only like, anyway, we've gone totally off topic. But you're treated only like a criminal and not also like a grieving parent until 10 hours later when they decide you're not a criminal.
You are a grieving parent. And that's where I think, why can't you have support, but also be saying, we think very much that your baby has died because of SIDS, and this is not your fault. This is what we have to do. But here's how we're going to support you while we get all the information.
That was so not the experience. That was very much so not the experience. I feel like there are certain people in this world who, like I've said to Alina before, like little heroes, like there are these like little heroes that make it possible to survive loss. And it's clear to me that you are like a big hero.
Thank you.
Little people that make it possible. People who like really are empathetic and who are just giving of their time. I'm sure that you see patients on your lunch break. I have no doubt. I know that you're the type.
It's more the ad to the end of the day, actually. I'm more the ad.
You're the ad at the end of the day. Yeah.
I like my lunch. I need my like 10 minutes to stuff my face. But yeah, it's more I like the end of the day, because then my last thought of the day is them, and I don't have to transition my brain. It's very hard to. Yeah. Oh, thank you. It's hard to transition your brain. So I put it where I don't have to transition if I can.
Makes sense. Yeah. All right. Well, thank you so much, Heather Flossie, Heather Fluorescent.
It was a pleasure.
Where can people find you?
Oh, yeah. I like Instagram the best. So it's Dr. Florescue, OBGYN. It just allows me to reply quickly and not have things all over the place. So
we will link
if you're in the Rochester area.
Lucky you.
Oh, thank you.
But I'm so sorry your baby died in the Rochester area.
To all of our wonderful new friends, we want to hear from you. Email us at aslongasimlivingpodcast@gmail.com and follow us on Instagram at aslongasimlivingpodcast. We'll get back to you as soon as our grieving brains allow.
Yay!